Okay, continuing on with the ECGs. So once you've reviewed all of that, we're ready then to start our ECG interpretation. So this is going to be some stuff that I'm going to upload for you, some little worksheets to get you practice, to get you able to interpret something healthy, something, an emergency, something like that. So let's start with our baseline, something that you should start to see and recognize as normal, right? So let's start with the normal sinus rhythm. So pretty small, right? And now I'm gonna upload some videos and another lecture on how to interpret what these little boxes and squares mean. But for now, let's just kind of look at what we consider rhythm. How do we know something is rhythmic? Well, we look at sort of the spacing in between, and they all seem to have the same, they're all about the same distance apart. So if I kind of find this big wave, I see, well, there's my R spike. So right before the R, there must be a P, Q, R, S, T. P, Q, R, S, T. So sinus, because I have P waves, right? There's P waves that generate that sinus rhythm. SA node is firing. So that would be a normal situation. Now, if I come over here, contrast B. So I see my R spikes, but I see a greater distance between these over here. So that means my heart rate is slower, right? And I see no P waves. So there's a R spike, but no P. R spike, but no P. So if there's no P waves, again, the atria is not controlling the heart rhythm. It's being controlled now by not the SA node, but by the AV node. And again, we call this junctional rhythm, in contrast to sinus rhythm. So on C, this is what we call heart block, and there's different degrees. There's first degree, second degree, third degree. I'm not really concerned that you know those distinctions at this time, but just understand that a heart block, there is some issue with the signal going from SA node to the ventricles. So in B, we know that SA node is damaged. It's just completely not there, right? So there's nothing happening in the atria. Over here in second degree, we do see some P waves. So there's a P, Q, R, S, T. So hey, there is some P waves. So the SA node still is doing its job, but not every signal is getting down into the ventricles. So let's see if we can find right here. So I have a P, QRS, normal. Now I have a P right there, but no R spike. Another P, R spike. Okay, good. A P, no corresponding ventricular contraction, no R spike. P. So some of the P waves are making it through all the way. Some of them are not, right? So the atria is contracting at its own rhythm, but the ventricles then are not getting the signal each time. So that's what we term as heart block. So it's still generating a contraction, but at the rate of this junctional rhythm here, right? So these two, junctional rhythm and heart block, are related, but they're not quite the same. Junctional rhythm, the SA node, the P wave is just absent. And heart block, the P wave is still doing its job, but not each signal is going to the ventricles. And then lastly, D, I hope you notice, like, wow, that's just a mess. I can't make sense of any wave. There's just a mess of squiggly lines, right? And this is when that heart is just basically in that tremor and those little twitching actions, right? So it's chaotic, grossly irregular ECG deflections are seen, and this patient is having a heart attack, right? They're in the process of dying right there. So we must defibrillate them. And again, this is where we get into the distinction of heart attack. There's two terms that are sort of used when we talk about heart attack. One is what we call the myocardial infarction, which was a blood circulation issue. There's a blockage in one of the coronary vessels. In ventricular fibrillation, circulation is fine, but our problem is with the conduction system. It's an electrical problem. So they have to be treated in different ways, right? So fibrillation must be defibrillated. Infarction must be, we must go in there and sort of open up the clogged vessels or do bypass surgery, some sort. But again, very, very different issues, but they can both be fatal, right? So we gotta be able to diagnose those as rapidly as possible. So with this, keep an eye out for a whole nother discussion on ECGs and interpretation and some little practice worksheets that I'm gonna send your way as well.